Ladies and gentlemen, please welcome your conference chair.
Hello. Good morning to all of you. My name is Anita Arnand, and welcome to this, the last day of the NHS Confederation conference. And boy, doesn't it feel like it. It's been a packed couple of days, really full. And yeah, you all have the look this morning, I have to say, of those who have networked a little bit too hard. Did you wake up like me, not to the sound of birdsong, but wheelie trolleys over cobblestones? So I know that all of you are sort of ready to go home, but I'm very pleased that you did stay for this last day, because it is arguably, I think, the most important day. We hear politicians talking all the time, chief execs, those of you who work in the industry, probably sick to the back teeth of hearing them talking. But I think Helene Donnelly put this really well. She said that there needs to be, and she was citing the Francis report, something Jeremy Hunt also cited, saying there has to be, in many respects, for any kind of change or reform or innovation to take place within the NHS sector, you have to have a buy-in from patients as well as clinicians, practitioners, managers, and providers. So today is all about those sort of the both sides of the fence, if you like, because you're not going to be able to clap with just the one hand. So before I tell you what we're going to do, in your fog of fragility, I think I probably ought to remind you of the safety concerns that we have here at this venue. So if there is an emergency, there won't be, but if there is one, you're going to hear an announcement on the tannoy which will tell you to please leave sensibly and quickly. And the muster point, just to remind you, is outside, in between the Jury's Inn and the Pizza Express restaurant. Don't come back under any circumstances unless somebody from ACC tells you that it is safe to do so. And also, I've been asked to remind you, you'll find some evaluation forms. Have you seen those, sat on them? Don't discard them. Please do fill them in. It's really helpful to the organisers to understand what has worked for you and what hasn't worked for you. So if you could fill them in and pass them back, I know they would be very grateful. So let's come to today. There's a theme. It really is. It's the other side of the fence that I mentioned a little while ago. From the patient's perspective, if you have an enormous monolith organisation like the NHS and you have to talk about change in any way, then it's useful to talk about the catalysts of those changes. And they can sometimes be very small voices. They have been very small voices in the past. But everybody we're going to hear from today is hoping to increase the volume on those small voices so that they are heard a little better, a little more clearly, and they have more impact. And you will be surprised, I think, from some of our personal stories today about how much difference one voice can make. So the first person I'm delighted to introduce you to is Ceinwen Giles. Now, you'll know Ceinwen as somebody who has worked for the United Nations, International Planned Parenthood, and a smaller cancer charity called the Shine Cancer Support Project. What you might not know is that Ceinwen has stage 4 non-Hodgkin's lymphoma. She was diagnosed in 2010. This is the horrible cruelty of that savage and awful illness, just 6 weeks after the birth of her daughter. So Ceinwen has one of those unique advantages of having been at a very high level within the United Nations, knowing how you guys operate and under what stresses you can operate, but then also being a patient who feels very vulnerable at one of the worst times, I guess, in your life. She's one of the only patients, I think the only patient, Ceinwen, on the King's Fund Advisory Board. So I'm really looking forward to what she has to say. Please welcome Ceinwen Giles.
Thanks. So as Anita said, I was asked to speak today on patient leadership and some of my experiences as a patient. And I also really want to talk about why I think patient leaders are a key actor in change within the NHS. But I wanted to start with a quote, because everybody loves a good quote. And it comes from a book that I used a lot in the work that I did in international development. One of the sort of key texts in development is a book called The Pedagogy of the Oppressed, which obviously doesn't sound like a light read. But it was written by a Brazilian education specialist named Paulo Freire. And he talks a lot about how leaders can promote change. And I think a lot of what he says has real resonance for where the NHS is now. So what he says is that revolutionary leaders do not go to the people in order to bring them a message of salvation, but in order to come to know through dialogue with them both their objective situation and their awareness of that situation. And he goes on to say that this active dialogue is really about creation and creativity and fostering creativity between people. And one of the things that I've always really liked about his work is that it focuses on the concept of dialogue and what it means to both speak to and listen to one another. And I'll come back to that a little bit later. Now, as Anita mentioned, I became interested in healthcare because in 2010, I became a patient. And having really never spent any time in the hospital, I managed quite an impressive feat of developing a life-threatening pregnancy condition, stage 4 non-Hodgkin lymphoma, and meningitis in 18 months. So I spent, all told, probably about 7.5 months in the hospital at various times. I was told that my chances of 5-year survival with the non-Hodgkin lymphoma that I'd been diagnosed with was 40% over 5 years. But I was lucky enough to get into remission, having spent 6 months in the hospital on a high-dose chemotherapy regimen. It did leave me with a chronic condition, and that's why I developed lymphoma. So I now manage a chronic immunodeficiency condition as a result of some of my cancer treatment. So obviously, it doesn't maybe sound like I'm lucky, but I do feel lucky in a lot of ways that I'm here and I'm able to speak to you. But one of the things that I really became aware of through my experience was that although a lot of the treatments I had were good, there were also a lot of areas that were ripe for improvement within the NHS. Now, you'll all be aware of Robert Francis's report and the recommendations within it. But one of the things that I did earlier this year was go back and look at some of the testimony that the patients and carers had made to the inquiry. And one of the things that really struck me was that a lot of the really terrible practices that were reflected in that testimony aren't really isolated to the Mid-Staffordshire Trust. They occur perhaps in more isolated circumstances, but they occur in a lot of hospitals. Like I said, I had a lot of excellent care in the hospital, but I also frequently saw or was subjected to bad practice. And this was anything from, doctors or healthcare assistants who didn't bother to wash their hands when they came to see me when I was in isolation, to nurses who didn't spell my name correctly, which meant that test results went missing. In one case, an operation was suspended. Or people who didn't take notes correctly, and so I either wasn't given medication or people wanted to give me double doses of medication. So I became really interested in what could be done to improve services and what I could do as a patient. And I became involved with 2 charities, Shine Cancer Support and also the Point of Care Foundation. And I also rather enthusiastically began applying for other patient involvement or patient participation opportunities. And I think a lot of this work was initially designed with very good intentions. There are people who really want to make a change within the local community, within hospitals, within trusts. Unfortunately, and I know this sounds really negative, but it is true, a lot of the opportunities I had for involvement were pretty uninspiring and in some cases quite depressing. I found in a lot of cases that patients were being brought into poorly designed processes where it wasn't clear what they were supposed to be doing or what the end point was. A lot of the meetings or events that I've attended are very time-consuming. They're always in the middle of the day. They are never paid. And as a patient, I've been asked for feedback in a lot of different ways, but it's not often clear to me what happens to that feedback or what change occurs as a result. And so you begin to question why you should give it at all. And I know that I'm not the only person that sort of questions patient involvement. I've heard a lot from people working in healthcare, and it probably won't surprise you to hear the things that they've told me, which are, oh, well, we got the same old suspects. And by that, they typically mean retired middle-class white people. Patients have an axe to grind. These people are just angry. They don't represent everybody else. Patients aren't able to contribute properly because they don't understand the system. Or the converse of that, that the patients have become too expert and they're too far away from the services on the ground and the realities facing patients now. So you're sort of caught in a catch-22. Now, a lot of these things can be true, and I have walked out of or come out of patient involvement meetings where I thought both the staff and the patients were really hard work, actually. But I think it's here that the concept of patient leadership becomes really important. If you actually want to transform the NHS, you can't keep doing the same things that you've always done and just add patients into the mix. I think the concept of patient leadership and achieving a real patient-led transformation means that you have to understand the roles and capabilities of the patient in a different way, and you have to engage in a different type of dialogue. Now, I mentioned that I used to work in international development, and one of the things that I've spent a lot of time over the last couple of years thinking about is how the experiences and the learning from international development can be applied to healthcare. Now, as an example, I worked on a project many years ago in eastern Sierra Leone, and they were trying to set up village development committees. And you don't need to know anything about Sierra Leonean politics to understand that these committees were being set up to shift power away from traditional and unelected chiefs towards regular people in the local villages. Now, what actually happened when they first set these committees up in a lot of the communities was that the chiefs basically became head of the committees and were just using the committees to do whatever they wanted to do and whatever they'd been doing anyway. But one of the key breakthroughs in the project came when one of the chiefs that we'd worked with for a long time came to understand that his community would never heal from the war if things kept being done the way that they'd always been done. During the war in Sierra Leone, a lot of people came back to villages and actually killed the chiefs, which obviously is quite extreme. But if you were going to create new structures that just reinforced power, nothing was ever going to change, nothing was going to be different. So this person actually became a real advocate for the project, and he acted almost as a translator between the local community and other chiefs in trying to promote change and shift power. Now, some of the most successful committees in that project actually were the ones where eventually power relations did shift, and you had local people who typically had never had any power involved in committees which could make decisions and shape services at the local level. And to me, there's a lot in this story that illustrates what we face in the NHS. There's a real need to create dialogue and to shift power. And it's not an exaggeration to say that in many hospitals, or some hospitals in the UK, where power is in an imbalance, people have died. So if we go back to the quote that I used at the beginning, I think one of the things that we need is revolutionary leaders. And these can be managers and clinicians who are within the system, and patients who see and experience the system differently. And there have, at this conference, been some really good examples of where that's happened. I think dialogue has to be important because it's not one way. It's not a process where patients give feedback and something may or may not change. But to really achieve transformational change, I would argue that patient leaders need to be embedded across your organization. They need to have real jobs with real responsibilities that are respected, and the organizational culture needs to accept that without them, business as usual will continue. So how can you do that? Well, I thought I would leave you with a few ideas. The first, which is probably quite controversial, but I think even given the current climate, you need to put some funding into this. If you don't put any money into it to support patient leaders, you're not going to get anywhere. If you don't have patients with the right skills, you need to consider how you can support them and train them to take on the roles that you want them to take on in a meaningful way. And you have to reward them for the work that you want them to do well. Second, I think you need to support your staff to truly understand the value of working with patients and to develop the skills to do this. Working with communities is a really skilled job. It's not something that just anybody can do without any proper training. It needs to go beyond showing a sort of short patient video at the start of a meeting. And I think people need to seek out examples where patient leaders have made a change and showcase those to the staff, because sometimes people need concrete examples before they're willing to make a change. And finally, I would argue that you need to experiment and you need to take risks. Ask yourself what you can do differently. Can you integrate patients into new roles or new ways of doing things? Can you work with them at different times of the day? Can you meet them in different locations? If you're getting the same old suspects, I wonder whether it's because you're doing the same old thing. And as we've seen from a lot of examples over the past few years, that same old thing really isn't good enough. And I think that patient leaders can really be a part of a new way of doing things differently. Thank you.
So it's probably a good idea now to introduce our panel, and we're going to discuss this a bit further now. To my left, Mark Doughty, who is from the Centre for Patient Leadership, and Lisa Rodigues, CBE, Chief Executive of the Sussex Partnership NHS Federation Trust. And both of you hold that unique position in that you're sort of on both sides of that experiential fence. Mark, first of all, tell us a little bit about what it is you do.
Okay. Along with my colleague David Gilbert, we founded 4 years ago the Centre for Patient Leadership, and its purpose is to support what Ceinwen's saying, basically. I mean, our role is to support patients to become leaders within the NHS, and to do that we help provide them with the skills and support them to really leverage the mindset that they've got, which challenges and supports the system to see things slightly differently. And we also work with the system to engage with patients and to engage with patients differently as well. And
also, I mean, you have something in common with Ceinwen in that you have been a user, you know what it is like to be the person who the chart is written about.
Yeah, I mean, the reason I'm doing it is because it was born out of my personal experiences. I developed rheumatoid arthritis when I was in my early 20s, and literally I went from being a very young, fit, active man to becoming quite severely disabled for a long period of time. And my experience was that the system, I know there are places where there's excellent care, but unfortunately I did not receive that. I remember being called, you know, we have the arthritic in the room, and being
Someone said that while you were there?
Yeah. And basically being looked at as a bunch of symptoms. And what wasn't taken account of was, hang on, as a young man with a condition which is impacting me emotionally and mentally and physically, how can you support me? And the one thing that they didn't do is they didn't build a relationship with me so that I felt included in this. So I basically went on my own journey, and through that experience discovered what I felt was an opportunity to do things differently.
Lisa, you've written really compellingly, I think, about what it is to be... No, I'm serious. But it sometimes makes very uncomfortable reading, but such is, you know, holding the mirror to truth. Your work as a chief executive of an NHS trust has been influenced by your own life experience. Just tell us a little bit about where you're coming from.
Okay, I want to start by saying my name is Lisa, because Kate's going to be speaking later. And
did I call you Kate?
No, you didn't call me Kate.
Oh, right,
no, you didn't call me. You called me Lisa.
Oh,
But I want to say my name is Lisa because it's a wonderful campaign.
Yes, thank you.
And I wanted to honour Kate, who's in the audience. And the
Too much networking, you're right.
And the second thing, Anita, I wanted to say is I took a decision last year to speak openly about my own experience of mental health services. I first saw a psychiatrist when I was 15. I thought that was a great thing to do, and people were quite nice about it. But then I went on to have my worst, I'd call it breakdown, ever. And I was very, very ill. And so I was a chief executive of a mental health trust. And there were some good things and some not so good things. And I'm happy to talk about any of those. But I suppose the thing I really want people in the room to understand is that 1 in 4 of you at any point in your lives will experience mental illness. Some of you, it will be as bad as it was for me. I wanted to be dead. And I absolutely hated and loathed myself. Feelings that were completely unreasonable, I now realise, because I'm not that bad a person, but I really felt, you know, I wrote a letter to the Queen to give my CBE back. Fortunately, I did it in the middle of the night, and I didn't know how to make our printer work at home, and I didn't think I could send her an email, so it didn't go, and my husband dealt with it. But all the people here are leaders. And one of the things that I've done in my career, I think, very badly, is pretend I'm all right when I'm not, and not talk about my own weaknesses, but my own sensitive points and the things that press my buttons and make me not as well as I might be. And I want everybody here to understand that you can be a better leader if you do reflect on your own needs and responsibilities, and you're more genuine. I think that that's the sort of leader that we need for this very future difficult time.
Yours is a really particularly interesting scenario, I think, because you're right at the top of a pyramid, which is notoriously stuffed full of alpha males.
Yes, yes.
For whom sort of weakness is a difficulty.
Yes,
It's
yes.
acknowledging
Yes.
or even being around it.
Yes.
Did you find after your big breakdown
Yes.
there was a period of time where they found it difficult to relate to you, and how did you bridge that?
Well, coming back to work after something like that, when you do a job like mine, it's very public, and it's all part of the recovery, but there's nothing harder, really. And so some people, I think, did shun me, but many people were very, very kind and supported me. I mean, there were good things, such as getting access to really good services, but there were bad things, such as not being able to use my own services, because as a chief executive, you can't. There's
Can't
this
be
thing
seen to be in that room.
well, not seen to be in that room, but there's this whole transference thing, so you have to go somewhere else to receive your care. But also, you have to pretend you're all right when you're not. We put on our slap, don't we, as ladies? And gentlemen, you make yourself look very, very well, and you come to work and you pretend. And so I think we've got to stop that pretense and be real and be ourselves in these leadership roles.
Leadership, that's a word that's come up again and again and again. Do we actually understand what that means? Can we just try and pin down what leadership is? What do you expect a leader to be?
Well, I think, a lot of what Lisa's talked about is it's sort of being authentic, isn't it? And being genuine and having a vision for what you want to change, but being able to get people to buy into that vision. So you're not doing it on your own. The best leaders aren't people who just come up with an idea and force other people to do it. They're ones who can kind of sell their vision and bring people along with it. And I think in the issue of patient leadership, that's one of the things that we need is patients who can share their visions and their ideas and are supported to do that, rather than just sort of, giving feedback on something and not...
Yeah, filling in an evaluation report.
Yeah, I mean, that's fine. That may well have a role. It's not like you need to get rid of all of that kind of stuff, but I think it needs to be more than that. And the concept of patient leadership is more than that. And that's one of the things, I think there is confusion about what does patient leadership mean. There was... I don't know if you saw it, but in the exhibition hall, there was a picture done by a cartoonist about patient leadership. And some of it was great. I mean, the artist was wonderful, but some of what was on there was consultation. It wasn't leadership. It was about listening to patients' voices, which is a very important part of it, but it's not that dialogue, it's not that creativity, it's not creating new things and taking them with you.
And it's also sort of creating the space for that voice to be heard, so you can pick that person out and say, you know what, you've got potential, we can do something with you. You're trying to make that space, aren't you, really? Trying to get establishments that are dense to create a space.
Yeah. But we're very fortunate because the people who come to us they have in them the innate leadership potential. I mean, for a start, many of them have long-term conditions, and in living with that, they've not only become great self-managers, they've become great self-leaders. They've got a sense, they've taken an opportunity to reflect on what does it mean to have my condition, and where do I want to go. So they've created their own personal vision for themselves, and they've created their own sort of sense of values. We just work with that. We just work with that material, support them, develop them, and give them the confidence, and then give them the skills to go out and engage with and develop. And I think, Ceinwen, you put your point on it. It's the dialogue, and it's dialogue as this process, and that's very often what patients don't get. So they have an opportunity to be the change they want to see. And I know it's a cliche, but it's so true.
I mean, I totally get the point that you've got brilliant people walking through your door, and I don't doubt it for a second. But the thing is, you can have a brilliant person, but they can then be lost in all of this. Yeah. This is so big and so vast and so populated. How do you then protect that asset and make sure that they're put in a place where they can be nurtured and they can grow?
I think by recognising that we are all human and we're all part of the same thing, and it isn't us and them. We're all going to be patients at some point in our lives. Some of us will need to use services more than others. So if I can see that these people are equal to me, these people who are looking after me, and they can see that I'm equal to them, and we treat each other as equals, we're more likely to listen.
So is that at a chief executive level that you have to have?
I'm talking about chief executives listening
Right.
to patients and patients listening to chief executives and us reaching agreement about what needs to change. And that's going to be the future, because we don't have enough money to go on doing it the way that we're doing it, but also the way we're doing it isn't looking after humans, it's looking after conditions all separately. But we're all humans and we're all whole. And Mark, thank you for what you said about your mental and your physical. I absolutely agree with you. You know, we're not separated. We need to provide care to people that is about the whole person.
I mean,
But can I just say, I mean, were you asking how the system can nurture them?
Yeah.
Are you talking about how they can nurture and support themselves?
No, I know. I'm asking how the system doesn't actually squash it out of them.
Well, they find it, again, it goes back to Ceinwen. They find it really difficult. Often they find it, they have a mindset. I mean, Helen Bevan sums it up perfectly. The system has a dominant mindset, which is about, unfortunately, a lot of the times seeing patients as data, collecting information. They find it very difficult to engage with them as individuals and build relationships. I mean, engagement is relationships, isn't it? And that's something that is incredibly difficult to do. So the challenge, I would say, to the system is to look at patients differently and look at them as human beings in order to engage in the relationship. And I know that sounds very generalist, but it's my experience, and a lot of people who come through our doors, that is their experience. They have not been seen as individuals.
It's not that it sounds general, but I'm just trying to work out how these good people go back to their villages and implement this. Because what you're talking about is a personal face-to-face engagement in many many occasions. And a lot of these people will turn around, and I'm going to open it up to you as well, so if your paddle people can just come down and be ready to take questions. I'm going to say, look, I'd love to. When am I meant to do this exactly? Where am I meant to get the time? You're asking for money to be put into this. You're saying, as the chief executive, there is no money.
I'm not saying there's no money for that.
You might save money in the long term.
I think so. I think this is an invest to save argument. There's a business case for this. Yeah. Why would we want to provide care to people that isn't helping them?
Right.
Why would we want to?
But that cultural will, because I think, I mean, just to give I was really taken by your examples, actually. They're really concrete, and they showed the problem, sort of meetings that are arranged at lunchtimes and things, when people at work. These are real practical considerations, poorly designed processes. Now, these are not done by design. People aren't messing up on purpose. They're trying to do good, but it's not happening. And then if you try and pin a senior official down, they'll say, God, do you want to see my to-do list today? So how do you work with that?
Well, I think you need people in the system who are trained to do it, first of all. Like I said, it's not something that's easy. You need to think through. I think you need to have a vision of what you want to change, how you want to bring patients into it, what role you want them to play, and then to break that down. I mean, almost like what Patrick was saying yesterday about breaking activities down into tasks. So if you have a vision for what you want to change, well, what do you want patients to do within that? I sat on a patient experience board for a cancer centre, and again, done with the best of intentions. It has made some really good changes, but it was very hard at the beginning to understand really what they wanted us to do, and the centre was so vast that you could feed into anything from who was, what type of coffee were they serving, to what plants I had on the roof garden, to stuff about waiting times at outpatient clinics. And I think it has to be, to some extent, up to the people in the system to say, right, okay, we really want to change this and we need your help. But also, what do you think needs to be changed? I mean, there has to be a dialogue, but it has to, you've got to at least maybe pick a few concrete things that you want to change, experiment with it, and then roll it out.
And also have a go-to guy.
I mean,
just a sort of a general, my own experience is down there compared to yours, but I had a wonderful experience having my first child, and it was a difficult delivery, but it was really good. And I just wrote a letter to the chief executive saying, you've got lovely midwives, and they are really, and I just hope you treasure them. They were really good to me, and they looked after me. And then I immediately got sucked into this chain of, do you want to be on our advisory board? Do you want to? Now, you know, when you're on maternity leave and you're a bit, you know, you've got time, you sort of say, you know, I'd love to. I think 7 months later, I had no answers to any questions that I was asking. I didn't know when any meetings were happening. I kept asking, but I got magazines.
Yeah.
I got so many magazines that I feared for the forest, to be honest with you. And I just wonder whether that, you know, I never did become involved. Because, and it just, I wonder how, you know, I mean, I sort of got busy then with work, but I wonder with how many people you create bad blood by doing something like that. I mean, what would be your advice to everybody here about that kind of thing?
Yeah, I think you need to know what you want to change and how you want people to help you, and to be open to their ideas as well. I mean, there's so many levels. Somebody asked me yesterday, they said, oh, we're hiring a new chief executive. Do you think we need a patient on the board? Oh, and I thought, well, actually, that's part of a much bigger question, right? It's not just the one person, and I think we have to go beyond thinking of patients as individuals. You have to think of them as leaders. And I mean, I know I'm being very general, but it depends on the problem you want to solve, but you need to maybe define that problem and then get the right people involved. And I don't think a lot of the time the problem isn't defined well enough.
Any questions? If you put your hand up really, really clearly. Yes, next, number 2, thank you.
Jeremy Taylor from National Voices. It's more of an observation than a question. I've loved all the speakers, and I haven't heard Ceinwen speak before. Absolutely fantastic. I just wanted to say National Voices has worked with the Centre for Patient Leadership and offered development training to patient leaders within our constituency and movement. It's been fantastic for them, so I can vouch for the really transformational effect of patient leadership training and development. It makes a huge difference.
Can you be clear about what kind of difference? Give us practical examples of where things have shifted.
These are people who are trying to make change within their local health systems. And the development training they get, it builds their knowledge and skills and confidence to be able to be really incredibly helpful leaders working with professionals in the system to change things for the better. So it's a fantastic resource, and I just want to say we should be investing in patient leadership. My challenge to everybody in the audience here is think about how you can invest in patient leadership. There is money out there. Huge amounts of money go into professional leadership training and to medical training, clinical training. The budget is vast. If we took a small bit of it and put it into patient leadership training, I think there'd be huge returns on investment.
Any other questions?
Sorry, can I just
yes,
follow?
Of course you can.
I think one of the things, because I've seen Mark and David's work, one of the things that is really valuable about leadership training is helping patients to move beyond their personal experience and broaden it out. And that's one of the criticisms that you hear a lot, right? And people have an axe to grind because they're angry about the one thing that happened to them. But actually, the leadership training, if you're training the right people, can really help people move beyond that and see their experience in a much broader context.
You can't expect to I mean, one of the complaints that often says is, do you know what? If we bring a patient into our hospital or into our organisation, invariably it's car parking or the quality of the food. Well, if you imagine patients, when they are parachuted in with no preparation to these situations, where they've had a relationship with the people in the room, which tends to be around them supporting them with their care, and now you're challenged with a different power balance, with no training or no support, they're going to go back to what can I talk about? Well, my expertise is the car parking. And that then creates a vicious circle, because then the people on the other side say, why are we bringing these people in? Because all they talk about is this. Yeah. Now, with this training that Jeremy's talking about, we've got people going in with the CQC, and through the ability now to ask really powerful questions, they go in and build relationships with the people in the organisations and ask questions that get them to think. And I think, but you have to train. You have to train people. You have to support them. Otherwise, they will resort to what they are used to.
And what they know, yeah, absolutely. There's a question here at the front, yeah.
Thank you. It's Andrea Sutcliffe, Chief Inspector of Adult Social Care at the Care Quality Commission, so following on nicely. Thank you for the plug, Mark. Just wanted to say two things, really. The first is this has been a fantastic session, and I kind of really wish there were a lot more people here to hear it, and so I'm really sorry that you're here on the Friday morning when actually an awful lot of folk who've been here on the Wednesday and the Thursday are gone. So fingers crossed we can resolve that in terms of timing for the future. Because actually, I think listening to all of you has been unbelievably inspirational and very powerful, and thank you all very much for doing that. The second thing to say, though, is that there's actually a lot of experience that we can draw from a health service perspective from social care. Yeah. And we've been working in co-production, truly trying to work with people to shape and design what either individual services look like for people, or indeed how services more broadly at a local level, or indeed nationally. And I've been working in co-production around trying to shape how we inspect and regulate adult social care. There's all sorts of things that we can all learn from each other, and I've tweeted some links for stuff for people today, but the Social Care Institute for Excellence is an absolutely fantastic resource, and I would really suggest that people kind of look beyond the health service to see how we can learn from others.
I mean, well, I'm going to get the panel to comment on that in a moment, but we'll look up your tweets, but if you can just give us the number one thing that people should take away from that social care model that you think is vital and powerful, what would it be?
It would be to look at the whole person, to actually, I think Lisa said it herself in terms of treat patients as human beings. I think it is about saying, folk can contribute not just because they've got a condition or whatever, they've got other skills and assets to bring to actually making things going forward. And I think Ceinwen, you've kind of really articulated that so well. And the other point that you made would be value it. Actually provide the proper support to make it work. Don't just think that people can come along and listen to acronyms, CITY, which is what we all do, and think that folk can make a contribution. We need to make sure that we support people in it being able to do this in a constructive way.
Thank you very much indeed. You have a question, do you? Is there anybody who operates on the chief executive level or chief operating officer who can tell me actually a real seismic change that took place maybe within your organisation because of that patient involvement? I think we'd love to hear that. Or the difficulties you have with getting patient valued and relevant patient engagement. We've got another 5 minutes if somebody would like to comment on that. But first, let's go to the questioner over there. Yeah.
Hello, Michael Greco. I'm Chief Executive of Patient Opinion Australia. Lovely to be in Liverpool and lovely to hear the talks. I think it's a fantastic session as well. I was really wanted to just make a comment on the treating people as human beings. I think suffering, which is what we deal with in healthcare, is about a great opportunity for us to deepen our understanding of our own human condition. And Lisa, you touched on that. Yes. And I call healthcare sacred space. So in the sense that it is a great opportunity to deepen that sort of understanding. How do you go about that within a trust with your staff to help them sort of, capitalise on that great opportunity? I know it's a very tough and demanding profession, but it's also a great privilege and opportunity.
Lisa, do you want to take that?
Yes. Well, and thank you, and it's great to see you because I've read some of your work. I think by truly understanding that we as leaders have to be kind to ourselves first, that then helps us to be kind and compassionate to the people who are in our teams, and that then helps them to be kind and compassionate to our patients and to the rest of society, the families that support them and the people that we work with. So if we don't look after ourselves, takes me back to that first point, we can't then go on and be kind and compassionate. My organisation, we've been doing a lot of work using mindfulness techniques with our teams, and people put their hands up and come forward for it. It's interesting who chooses to and who doesn't, and how people can be encouraged. But just this week, we had a couple of hours for my executive team. One of my team members is in the audience here. Some work on our own self-compassion. I think it's probably been the most important meeting that I think we've had for quite a few years, because we came away from there feeling much more complete, much more confident, much calmer, but also much more able to listen to the very difficult messages we have to listen to, which is that we don't get things right all the time, and that many of the things we do for people are actually very bad for people. So we have to start with ourselves, I think, and thank you for that opportunity to answer that question.
I think we've got a chance for one more question. Over there, number 3.
Thank you very much. I'm delighted to be the last question. I'd like to just really ask the panel Maeve Holly, I'm the Chief Executive of the Patient and Client Council in Northern Ireland.
Thank you.
I'm delighted to be here. My question for the panel is really the idea that we quite often ask people, how was it for you?
Yes.
Rather than, how would you like it to be?
Yes, yes.
And how do we move away and get people involved much earlier on so that it's not always this, the experiential, but rather a vision of how...
It's a very, very good question. Who'd like to take that first? Mark?
Are you talking about for the patients? Are you talking about for the patient leaders?
For the organisation.
Right, well, the one thing is that, again, there's a huge wealth out there of people, if you can tap into, who want to get involved and are inspired to get involved. And virtually all of them want to get involved because of either a personal experience or a family experience. And most of them have very clear visions of what they want to see as being different. And even if they don't know, they come in to start with because they know what they don't want. And by working and supporting, you can translate that in what they do want. So they bring that into the system. If you can listen and you can hear that and you can ask the questions to draw that out. On the other side, I think that's just exactly it. It's this solution focus, isn't it? It's this idea of not just focusing on the problem, but actually looking at what the solution can be. But I don't need to tell you that. You all know that. You're all involved in that. But it's that solution focus, that appreciative solution focus, that idea of being optimistic and focused on it. And I know it's really difficult, but it can create difference in the relationships and the engagement of the groups of people working together.
We're very much running out of time, but a very brief comment from both of you, if you can.
Yeah, I was just going to say, there are a lot of tools that you can use when you're working with communities. So I know I spoke at the King's one last year, and I had a lot of people come up to me afterwards and say, yeah, it's great, the thought of talking to patients, but we're actually quite frightened about what they might say. But there are ways, like Mark was talking about, sort of appreciative inquiry techniques that you can use when you're facilitating sessions, which do really focus on building a vision rather than focusing on the problems. Obviously you have to talk about them, but yeah, it's building a collective vision, I think, and using the right techniques. Lisa?
Oh my goodness, I just think it's about really listening, really listening very, very carefully, and not listening to what the words that they're saying, but listening to what they're trying to say. Of course we should plan. We should plan for every part of our life. We've only got 2 things we know will happen. One is we're born and the other is we'll die. So let's talk about the bit in between. And yes, of course, we should plan in advance.
It's been a really, really helpful session. Thank you all very much indeed. Could you please show your appreciation for Lisa, Mark and Ceinwen?